Welcome to the Nutrition Pearl, Nutrition Support of Children with Chronic Liver Disease, Part 1, presented by the Council for Pediatric Nutrition Professionals. How should you approach nutrition support of children with cholestasis? You will want to start by estimating energy and protein needs. For energy needs, requirement depends on resting energy expenditure, REE, activity level, and severity of maldigestion and malabsorption. Indirect calorimetry is the gold standard for estimating REE, however, is not widely available. Therefore, predictive equations, or the dietary reference intake, DRI for age, should be used for baseline requirements. For protein needs, you should also use the DRI for age for baseline requirements. Estimated energy and protein needs should be adjusted based on the patient's nutrition status. Due to maldigestion and malabsorption, these children typically require approximately 130% of energy requirements for age and may even require greater than this. They also require 130 to 150% of protein requirements for age. Fat and where fat comes from requires special consideration in these patients. In the human body, there are long-chain triglycerides, LCT, and medium-chain triglycerides, MCT. LCTs require bile and pancreatic enzymes for digestion and absorption and need to be incorporated into micelles and then chylomicrons for entry into the lymphatic system. MCTs do not require bile or pancreatic enzymes and are directly absorbed into portal circulation bound to albumin. In children with cholestasis, fat should account for 30 to 50% of total calories. Because MCTs do not require bile salts for digestion, they are helpful in meeting nutrient needs. There is limited data that shows that cholestatic infants had improved growth when fed a ratio of 30% MCT to 70% LCT. Start with this ratio and increase MCT if there is suboptimal growth with or poor tolerance of LCT. One important thing to be mindful of is essential fatty acid deficiency, EFAD, which can occur if MCT supplementation exceeds greater than 80% of total fat intake. Children with cholestasis also have higher micronutrient needs and are at high risk for fat-soluble vitamin deficiencies. You will want to monitor fat-soluble vitamin levels to avoid and/or treat deficiencies. Included here are the different laboratory tests that should be used to monitor fat-soluble vitamin levels. These levels should be rechecked every 3 to 6 months. Consider assessing more frequently depending on severity of maldigestion and malabsorption. Some severely cholestatic patients may need to have fat-soluble vitamins checked monthly.